Good morning, guy. Today we will talking about introduction to cardiovascular surgery, current trends in cardiovascular surgery. I think everybody of you know what is cardiovascular surgery. This is surgeons who works with the heart and with the vessels, what are near or some deeper out of heart. Yeah. Um, But I think that you don't know this man. It is a doctor, Daniel Hall Williams. The first successful surgery on the heart is attributed to this doctor, who repaired a traumatic laceration to the right ventricle in 1893. Cardiac surgery, as we know it today, began in the early 1950s, yeah, with the development of the cardiopulmonary bypass machine. And all this lecture you will see and hearing about this machine. A motionless and bloodless surgical field was necessary to advance the discipline of cardiac surgery. After a decade of some successful cardiac procedures such as coarctation repair and patient ductus anteriosus closure, the 1940s ended with a clear understanding that further progress would require a cardiopulmonary bypass machine that could facilitate an immobile and clear field. By 1958, the Myocardial heart-lung machine was commercially available from a manufacturer, custom engineering and development. Additionally, in 1955, and only 19 miles away from the Mayo Clinic, Dr. Lillehei of the University of Minnesota successfully operated on patients with a bubble oxygenator developed in his laboratory by Richard DeWall, one of the first open-heart perfusionists. It was quickly recognized that significant perioperative complications were just as important to the patient's well-being as the repair of cardiac pathology utilizing a heart-lung machine. Morbidity observed in the early days of cardiac surgery would not surprise any anesthesiologist or surgeon even today. For instance, postoperative coagulopathy and bleeding were frequently encountered. Additionally, air embolism were common as well as equipment failures and cannulation problems. Furthermore, many surgeries ended tragically because of preoperative misdiagnosis. This included Gibbon's first surgery on a human patient employing a heart-lung machine, where a 15-month-old patient diagnosed preoperatively with an atrial septal defect actually had a large PDA, a fact only recognized post-mortem. Surprisingly, today's intraoperative transesophageal echocardiographic exams still uncover up to 27% of surgically relevant undiagnosed pathologies. Finally, given the extremely high risk of surgery, only patients with no other medical options would undergo these procedures, making the risk even higher. The high burden of morbidity required ongoing care beyond the operation theater and in part gave rise to the first cardiac surgical intensive care units. Yeah, it's very important to check the patient condition after this operation, and it is very important to see absolutely all levels of the health in the monitoring. What is heart surgery? Heart surgery can correct certain heart problems when other treatments haven't worked or can be used. In some cases, heart surgery may be a medical emergency. For example, surgery for a severe heart attack may need to be done right away. In other cases, you can plan heart surgery ahead of time. Some heart surgeries are minor operations, such as heart bypass surgery for blocked arteries in the heart. Other surgeries are more minor heart procedures, such as putting in a pacemaker. There are different types of heart surgery that can help treat many heart conditions: coronary artery disease, heart valve disease, arrhythmia, heart failure, heart aneurysm, angina, damage and and abnormal heart structures, including congenital heart defects. Yeah, seven conditions what we can help the patient. Uh, Coronary artery disease. When a sticky substance called plaque narrows or blocks the arteries that supply blood to your heart muscle. What we can do, makes a new path for blood to flow around the blocked part of an artery in the heart. This is called a coronary artery bypass graft or heart bypass. It is the most common heart surgery in adults. Yeah, in the picture you see that we have normal artery and red blood cells. Yeah, and we see not normal artery with the plaque. And of course we can understand that sometimes the arteries they have the muscles wall, and when something happened they will decrease the volume of artery. And if there is not just a normal way, yeah, if there will be a plaque, we will have a big problem for patients, because the plaque do not change. It will be the same size, and the artery will change, and it always lead to the some problem for patients like a cardiac attack. Heart valve disease. Problems with the valves that control the flow of blood through your heart. Repairs heart valves. Replaces heart valves with a mechanical valve or biologic valve made from pig, cow or human heart tissue. Yeah, in the picture you see the stenosis, and you see that valve doesn't open properly, and there you see a normal open. Regurgitation, the valve doesn't close properly, yeah, and the normal closed valve. And you know that we have full valve inside the cardiac, inside the heart, yeah, first, second, third and fourth. About these valves we will talk in more intensively in the practice. Arrhythmia. Problems with the rate of rhythm of your heartbeat. They are caused by changes in the electrical signals that control your heartbeat. Places a pacemaker or an implantable cardioverter defibrillator in the chest to correct your heartbeat. Treats atrial fibrillation with small cuts in the heart muscle, that cuts from scars that make a path for the heart's electrical signals. Mace surgery. Yeah, you see the normal heart, and there we have the sinus node, what gives the electrical start of the working of the heart. Yeah, and you see the atrioventricular node and normal electrical waves, yeah, from signal sinus node. Yeah, how you remember, and when we look to the ACG we check sinus or not sinus written, yeah, and sinus give us the first signal, yeah, and it give us to the atrioventricular node, and this node give the myostimulation, yeah, of the ventricles and of the atriums. When we have the problem with arrhythmia, yeah, we have some more nodes what give atrial fibrillation impulses, and it all give chaotic signals. and you see that we haven't got normal signal in all ways like there, yeah, just in the one way. And there we can have the rapid ventricle impulses what blocked the normal electrical myostimulation. Heart failure. When your heart is too weak or stiff to pump enough oxygen-rich blood to meet your body's needs. What we can do, places a device in the chest which may include an implantable cardioverter defibrillation ICD to help prevent sudden cardiac arrest, a biventricular pacemaker to coordinate the heart's pumping action so it's more powerful, a ventricular assist device to help the heart pump blood, a total artificial heart to pump blood for the heart. Replaces a seriously diseased heart with a healthy heart. Heart transplantation. Heart aneurysm, a balloon-like bulge in the wall of an artery. It can be life-threatening in the aneurysm tears or bursts. Repairs or replaces the weak part of a heart artery using a patch or a tube made of fabric. I don't find the picture about the heart aneurysm, maybe because it is not so often pathology. Yeah, but I found the aortic aneurysm pictures, and you see that it is a dilation of the vessel. Yeah, and you see the vessels inside the cardiac heart. Excuse me, inside the heart. Yeah. And just thinking that the vessel inside this heart was dilated. Angina, chest pain from coronary artery disease. What we can do, use a laser to make small channels through part of the heart muscle, transmyocardial laser revascularization. Damaged and abnormal heart structures, including congenital heart defects, heart structure problems that you are born with. What we can do, repairs heart damage or problems with how the heart and blood vessels are formed. Repairs depend on the type of defect or damage. Ventricle septal defect, ventricle septal defect, septal defect. No, there we need have the hole, yeah, and there you see this hole, and when we have the ventricle structure, some blood will go to the right ventricle, and it lead to hypertrophy of the right ventricle. What approach do surgeons use to heart surgery? Of course, it's we need to understand that for any problems we have another approach. Yeah? For example, we can use open heart surgery, off-pump heart surgery, minimally invasive heart surgery, and robotic assisted surgery. Open heart surgery, in the name of this type, you understand that also called traditional heart surgery is when the surgeon cuts the chest open to reach the heart. Because it's difficult to operate on a beating heart, medicines are used to stop the heart. Bypass machine, yeah. A heart-lung bypass machine keeps oxygen-rich blood pumping through the body during the surgery. And we have the mid-cap surgery, but we will talk about this in the next slides. Off-pump heart surgery is open heart surgery on a beating heart without using a heart-lung bypass machine. The surgeon holds the heart steady with a device. Surgeons may use off-pump heart surgery to do coronary artery bypass grafts, but only in certain cases. Yeah, and you see this machine, it's really hard to understanding if you don't work with this machine, but all what you need is that this machine working to do oxygenation of all organisms without your heart. Minimally invasive heart surgery uses small cuts between the ribs, the cuts may be as small as 2-3 inches, the surgeon inserts tools into the chest through the cuts. This type of heart surgery may or may not use a heart-lung bypass machine. Yeah, we call it mid-cap surgery. Robotic-assisted surgery is a type of minimally invasive surgery. The surgeon uses a computer to control tools on the arms of a robot. This allows surgeon to be very accurate when doing difficult operations. Complications: bleeding, infection, fever, and swelling, a problem from anesthesia, medicine that makes you sleep during surgery, arrhythmia, damage to the heart, kidneys, liver, and lungs, stroke. A wide variety of surgery is carried out by cardiothoracic surgeons, including cardiac surgeons, thoracic surgeons, congenital cardiac surgeons. Coronary artery bypass surgery, we use heart valve surgery and aortic surgery. Thoracic surgeons, surgery for lung cancer, tumors, and cysts, surgery on collapsed or infected lungs, keyhole thoracic surgery, video-assisted thoracoscopy surgery, and chest wall deformities. Congenital cardiac surgeons, working with septal defects, aortic and pulmonary valve stenosis, transpositions of arteries. How you remember in the starting of the lecture, I tell you that cardiopulmonary bypass heart-lung machine is very important for this topic, yeah, and it is revolutions cardiac surgery, allowing precise intracardiac repair while vital organ perfusion, oxygenation, and function were maintained. The essential components of the CPB circuit are described in box 61.1. Venous cannulus drains blood from right atrium or both vena cava. Suckers return shed blood from operative field to the reservoir. Drainage sump of venous and shed blood to be collected and then oxygenated. Oxygenator, venous blood oxygenated across a membrane. Heat exchanger cools and rewarms blood and turby the patient. Roller or centripetal pump performs function of left ventricle, flow rates of 4-6 liters in minute. Arterial cannula returns oxygenated blood to the distal ascending thoracic aorta or other myoartery. I think that it is very easily box for remembering this one. The duration of CPB for most operations is between 1 and 2 hours. Complex operations may require 3-4 hours of CPB and occasionally several days or weeks. Mere shortcomings are blood cell destruction, roller pump, leading to hemoglobinuria and thrombocytopenia, coagulation factor consumption, and systemic inflammatory response due to contact, as well as neurological pulmonary renal and hepatic dysfunction. All these problems are time-related, becoming noticeable after 2 hours of CPB. Hypothermia is used to help protect vital organ function against brief periods of possible hypotension. Hemodilution is used to help reduce blood product use, reduce red cell loss during surgery, and improve small vessel blood flow in hypothermic conditions. For complex surgery of thoracic aortic arch aneurysm, CPB is used to cool the patient to 18 degree. Profound hypothermia. Blood is drained into the CPB reservoir and the circulation arrested for up to 60 minutes, allowing excellent and rapid asanguineous access to mere vessels, yet maintaining cerebral and renal protection. In the completion of the vascular procedure, the patient is rewarmed to 37 degree over 30-40 minutes. I think that the box is more easily for understanding and remembering this cardiac bypass machine. Deep hypothermic circulatory arrest techniques are also used to facilitate surgery on or within the inferior vena cava, especially in venous extension of renal neoplasms into the renal vein and inferior vena cava, where precise, safe clearance of the endovascular extension is required. CBP is not always necessary. CABG, cardio-artery bypass graft, can be performed without using the heart-lung machine and indeed is the preferred technique for some surgeons either routinely or when the aorta is hostile, when any manipulation of the aorta may result in an embolic stroke and in closed cardiac surgery. Myocardial protection. In some conditions, it is possible to perform an excellent cardiac operation using CBB, but with the heart normally perfused and beaten, for example, closure of an atrial septal defect. However, precise coronary artery anastomosis and complex valvular procedures are best performed in a still, flaccid heart. Ideally, this state is achieved by clamping the distal ascending thoracic aorta and infusing cardioplegia solution. Oxygenated blood with additional potassium, magnesium, indocyanine, and amino acid substrates at 10-20 degree in order to arrest the heart, reduce its metabolic requirements and provide appropriate substrates, thus protecting the heart while being operated upon and being deprived of its normal coronary blood flow. There are many formulas of cardioplegic solutions and methods of administration, also the principle remains the same. There you see the picture with cardioplegia solution, how it looks like. Cardioplegia is also frequently administered retrogradely via the coronary sinus, using specially designed cannulas in addition to antegrade administrations. This technique is particularly useful for protecting the myocardium downstream from very stenotic or occluded coronary arteries or when the heart is positioned such that it is difficult or inefficient to easily administer further antegrade cardioplegia. The usual cardiac arrest times are 45-90 minutes, also up to 180 minutes, if possible with preservation of cardiac function. Sinus rhythm is usually restored within 1-2 minutes of re-establishing coronary blood flow. Closed cardiac surgery. Many procedures do not require CBP. The early operations were performed with the heart beating. Such operations are possible where they are removed from the heart, such as closure of patient ductus anteriosus. Yeah, you see this one, ductus, Batalov ductus, we call it in Russia. Or where disruption of cardiac function is transient and can be well tolerated. For example, mitral valvotomy. Mitral valvotomy. Mitral valvotomy. When, for example, we just with finger punched or puncture this valve. But of course now we don't use the finger. With the evolution and the refinement of imaging the technology, many closed and some open operations have been replaced by endovascular or percutaneous transcatheter techniques. For example, dilatation of aortic coarctation, PDA closure, atrial and ventricular septal defects, and more recently aortic pulmonary and mitral valve replacements and mitral valve repair. Operations commonly performed without CPP are listed in box 61.2. The vast majority of cardiac operations worldwide are performed using CPP. What we can do without CPP, it is PDA closure, coarctation of aorta repair, mitral valvotomy for mitral stenosis, pericardiectomy, coronary bypass. Coronary artery surgery. coronary atherosclerosis is a major disease process in Western countries and is rapidly increasing in incidence in developing countries. Coronary angiography by retrograde cannulation of the coronary aorta via the femoral or radial artery under local anesthetic was introduced in 1962. Coronary bypass surgery became established in 1968 and coronary angioplasty in 1978. Pathology. Atherosclerotic stenosis articulations develop proximally at the origins of main coronary branches or at major branching points. The coronary vessels are usually free of disease distally. A stenosis of more than 50% diameter loss is considered significant. Atheromatous plaques may disrupt, occlude or suffer from intraplaque hemorrhage, causing acute spasm, occlusion or thrombosing. Gradual progressive chronic stenosis causes angina. Acute spasm results in ischemic chest pain at rest and thrombotic occlusion result in acute myocardial infarction. Risk factors for coronary artery disease include family history, male gender, diabetes, hypertension, smoking, hypercholesterolemia, and obesity. Angina pectoris on exertion is the most common symptom. Ischemic chest pain occurring spontaneously at rest also occurs and is associated with spasm in the vicinity of the stenotic plaque and or transient coronary artery occlusion. Myocardial infarction occurs with prolonged or permanent coronary occlusion resulting in severe chest pain lasting several hours. Diabetic patients may not experience chest pain because of neuropathy. Between 10 and 15% of patients, especially women, may experience atypical symptoms such as back pain, epigastric pain, throat or jaw discomfort. Myocardial infarction must not be confused with the symptoms of acute aortic dissection, which presents as sudden and dramatic severe interscapular pain, as opposed to the progressive crescendo of myocardial infarction. I have the interesting case in my studying when I was in the 6 or 5 year of education. I working like a nurse in the hospital, in the surgery department, and when I come inside my duty, I see the patient with the pain in the abdomen, and I look to his history, and there was a diagnosis acute pancreatitis. I thinking that this diagnosis it's not right, and I try to check him. After all measurements, I understanding that it's not acute pancreatitis, but I don't understand what is it. I check the history. In the history, we have absolutely all X-ray, ultrasound, blood test, but haven't got a ECG. And I think maybe I need do a ECG. I check the ECG and there I find the myocardial infarction. Yeah. I tell to this man that he has the myocardial infarction. He tells that it's not possible because he have pain inside the abdomen, not inside the heart. Yeah, and I call in the doctor of cardiac department. He looked to him and tells that is really infarction. For what case I want? Why I tell you this case? At first of all, because I won't tell you that I am very good in 5 years of education, and the second one that ECG always is very important. Check it every time. Sometimes it can save the people's life. Investigations. Chest X-ray may indicate cardiomegaly of or left ventricular aneurysm as a result of prior myocardial infarction. ECG may show ST segment elevation or depression with acute chest pain or Q valves due to old myocardial infarction. Stress test, treadmill or bicycle with ECG monitoring, where positive will result in chest pain, CT segment depression and a fall in blood pressure. Thallium, sestamine and positron emission tomography scans may indicate areas of hypoperfusion, ischemia, viability and reversibility of left ventricle function. Computed tomography is useful for screening, especially in young patients presenting with chest pain. If negative, this excludes coronary artery disease. Conversely, a high calcium score indicates a high chance of coronary artery disease. Currently, coronary angiography is then required as the definitive investigation to outline the number, location, and severity of the stenotic lesions, and the size and quality of the vessels beyond. Coronary ultrasound. Intravascular ultrasound details the extent, severity, and nature of coronary artery plaques, especially useful when evaluation on coronary angiography is uncertain. Fractional flow reserve is measured by an intracoronary pressure wire at the time of angiography and provides a physiological assessment of the degree of ischemia distal to the stenotic lesion. A pressure drop of more than 20% across the stenotic lesion is considered significant and allows an objective evidence-based and targeted strategy towards revascularization, which in turn results in better short and long-term outcomes. Functional flow reserve, it is a distal coronary pressure between proximal coronary pressure. The syntax score developed for a randomized trial of coronary stenting versus CABG allows scoring of the severity and complexity of coronary lesions and choice of appropriate revascularization strategy. Angioplasty and stenting for discrete short lesion in one or two arteries, CABG for complex of bifurcation lesions in multiple coronary branches. Step 1 dominance, Step 2 coronary segments, Step 3 total occlusion, Step 4 trifurcation, Step 5 bifurcation, 6 aorta ostial lesions, 7 severe tortuosity, 8 lengths more than 20 mm, 9 heavy calcification, 10 thrombus, 11 diffuse disease, small vessels, and Step 1. Medical management: low-dose aspirin nitrates, beta blockers, calcium antagonists, and cholesterol-lowering agents. Indications for intervention: uncontrolled symptoms, where symptoms persist despite appropriate medical therapy or where medication cannot be tolerated. Prognosis: patients with severe stenosis in the left main coronary artery, proximally in a large left anterior descending artery, or when all the main coronary arteries have severe stenosis. Revascularization has been clearly shown to provide more long-term prognostic benefit. Discrete stenotic plaques in one or two arteries may be treated by percutaneous transluminal coronary angioplasty to dilate the plaque to its normal lumen size 2 to 5, with the plaque held open by placement of a stent. Advanced include drug-eluting stents, which inhibit proliferation of neointima and have reduced in-stent restenosis rates to 1.5% at 1 year. Multiple severe coronary artery stenosis associated with chronic uncontrolled angina or unstable angina are best treated surgically. CABG comprises 60% of all adult cardiac operations. There are many variations of surgical techniques, but the general principles are as follows. Sternotomy is performed. The left internal thoracic artery is harvested and is usually anastomosed to the left anterior descending artery, which is considered to be the most important artery. In younger patients, the right internal thoracic artery is harvested and anastomosed to the second most important affected coronary vessel. Other coronary vessels are grafted using either the radial artery or saphenous vein. CBP is used and the heart is arrested and protected with cardioplegia while performing the distal anastomosis. The proximal graft anastomosis may be performed to the ascending thoracic aorta while the heart is arrested or using a specially designed clamp. Alternatively, the proximal inflow may be from the subclavian artery or via the constriction of pedicled grafts of the internal thoracic artery. Typical operations take 3-4 hours, including cardiac arrest for 30-60 minutes and bypass times of 60-90 minutes, depending on the number of bypass performed, average of 3 to 4. The pericardium is usually loosely closed to protect the right ventricle. In further sternotomy, drain tubes placed behind the sternum and into the pleural cavities if they have been entered, and the sternum reversed so that it is extremely stable. The patient spends 24-48 hours in the intensive care unit where blood pressure, right atrial pressure, pulmonary artery pressure, left atrial pressure, and cardiac and urine outputs are measured, and interventions performed as appropriate. The patient is mobilized on the first or second postoperative day, and aspirin, a statin, and beta blocker and calcium antagonist are recommended. Most patients are discharged from hospital 5-6-7 days postoperatively. Recovery is rapid, with most returning to office work in 4-6 weeks and to full activity within 3 months. Thank you very much for your attention. See you on the practice. Bye bye.